next speaker, who is Dr. Swanson. Is there a role for mesh or ADM in breast augmentation?
Okay, thank you. It's nice to hear people thinking outside the box. I'd like to thank the host for inviting me and also for welcoming a different perspective. So I'm in private practice. I'm in Kansas City. These are my disclosures, just royalties on 2 books on evidence-based cosmetic surgery. Now, the internal bra, we hear about it all the time. Patients ask about it, but it's not a new idea. These South African authors described it years ago. You can see on the right, trying to construct a 3-dimensional, like a bra. But if you look at the before and after pictures, they really don't substantiate the claims. You don't see the increased projection or upper pole fullness. Most women are not going to be happy with that result. You may remember Dr. Goes 20 years ago, the second skin technique. These are the pictures that he published, but if you match them for size and orientation, you see that he's really not increasing projection or upper pole volume. This is Galaflex being applied to the lower pole, but the problem here is the lower pole is being preserved using this method. Now, the late Dr. Flowers called this the mastopexy wrecking bulge. And here are the before and after pictures from a publication. Again, I've matched them for size and orientation, and you can see the results just do not bear out the claims. I mean, these results are not going to impress most patients. There's a volume loss, and in fact, the patient does look like she has pseudotosis. And there's a frequent COI of authors, both the authors of these papers. This is Dr. Malucci's paper just a couple of years ago in ASJ. Again, I've matched the photos using skin markings to try to line them up the best I could. Before on the left, 3 months, although there's still some redness and bruising in the middle. 1 year on the right. Again, most patients are not going to be too impressed with that result. And this is with mesh and mastopexy. And Dr. Malucci, he claimed no conflict, but in other publications and presentations, he evidently does have a conflict with the company that owns the mesh manufacturer. So vertical mammoplasty, no mesh, what are the long-term results? This is what I do. And we really need to focus on the correct mammoplasty method and not the mesh. It's surgery, it's not the product. And look at them for over a period of 10 years. That's what's missing. And I actually have a publication on this where I did look at the results over 10 years, and I found that this technique held up well. And this is just a diagram. These are actually real measurements from my study, just showing how the vertical technique, and this is no mesh, holds up well over time. In this systematic review, the authors conclude available data indicate the meshes do not effectively prevent recurrent ptosis and bottoming out. You really have to use standardized photographs and breast measurements. This is often the missing link. I've been doing this for years. I developed my own 2D system, and most of what I've learned about my own results has been by using this method to measure my results before and after surgery, and I've learned a lot of things doing that. Now, Dr. Parody showed this slide earlier, just comparing the different mammoplasty techniques. Really, the vertical mammoplasty has the best basis in geometry because it trades width for projection. Inverted T mammoplasty trades projection for width, which is why today you see a lot of flat, square breasts. That's just a consequence of the over-elevated nipples. Those are geometric consequences of using an inverted T inferior pedicle technique. So this is a method that I use very regularly in my practice combination. I call it all seasons vertical augmentation mastopexy. It gets the job done. The implant gives you the volume, and the vertical lift gives you the vertical lift that you need while minimizing scars. And this slide was presented earlier as well. It's so simple, I don't even know if it qualifies as an algorithm. But basically, in almost all my female breast cosmetic patients, I'm either doing implants or a vertical lift or both. I mean, it's that simple. And now, what about ADM? We're going to switch to ADM now. The first report was from Maxwell and Gabriel, and they reported 100% success. I'm always a little skeptical when it's 100% success. No IRB, and the combined payments to the authors, I looked that up. I'm going to be talking more about this yesterday, but the authors actually were paid over $40 million. That's mainly Dr. Maxwell, mainly for royalties, but still a lot of money from Allergan. Now, what about capsulectomy and ADM insertion, a new paradigm? This was a very popular study published by Dr. Hidalgo and Weinstein and PRS in 2020. I think it might have been the most read cosmetic study, But what they did was they used ADM for women with bilateral capsular contracture. That's primarily, the first time they developed that, or unilateral treatment failures. They used Stratus. The problem was that in their analysis, the follow-up time, of course, was shorter for their more recent ADM cases, and there was no reported complications in this study. So what about ethical problems when recommending ADM? And I'm talking about cosmetic surgery, and this is for capsular contracture. Well, cheaper than failure is actually not true when you compare it to my recommendation, which is an open capsulotomy. And surgeons may and patients may not be informed of a much less traumatic and less expensive alternative. Now, if you recommend this to patients, it's going to be financially debilitating for them. Usually it's not covered by insurance, no prospective controlled study, and treatment failures do occur. And if you're quoting success rates, you have to consider that if you're missing patients that can't afford the surgery, those patients are treatment failures. They're not able to afford the surgery. And again, no IRB approval. So capsulectomy and ADM, it's a much longer, more difficult, expensive surgery. You're taking out the existing capsule and then you're having to reline the breast. It is sometimes dangerous, and I'm aware of one death and one axillary vein injury. You lose control of the pocket, which is why you need to put in new lining. Reminds me of Paul Newman in that old Cool Hand Luke where he has to dig the hole and then fill it again. You're just going to a lot of trouble. So why perform capsulectomies in the first place? Why are people removing capsules? Well, they've never been shown, this procedure has never been shown to provide a systemic benefit, except for BIALCL. Existing capsule is better, it's vascularized. Nobody's ever identified a bacteria or microbiome linked to capsular contracture. And it doesn't make sense to remove part or all of a capsule because you're not changing the microenvironment of the breast in doing so. It's not even known to be helpful for BII compared to a capsulotomy alone. This was just a recent publication. So ADM is actually a case study in problems created by COI, which again, I'm going to talk about tomorrow. They're underreported. Researchers, of course, publish more positive outcomes when using ADM. If you've got, if you're getting a lot of money from the manufacturer, you're going to be more likely to report positive outcomes. It's well known. It's beyond argument at this point. This was a commentary by Dr. Bengston saying that he thinks that withholding ADM is like not offering curative medicine, and my technique that I use is basically insane. And he received almost $1 million in Allergan payment over a period of 2013 to 2022. So what about the complications? I mentioned complications not being reported. Well, this is just a list of complications that I compiled for these procedures. Dr. Weinstein talked about this recently. Again, did not report any complications or revision rates. But I imagine this surgery is so difficult and it's lengthy. If you're able to do it without any one of these complications, that would be quite an achievement. So what's the alternative? You've got to have an alternative. So what I do is just an open capsulotomy. I published this in 2016. It's largely been ignored. And these are my complications. The recurrence rate 22.7%, but very few other complications. Now, so what I do is I just take the first rung of the ladder. I do an open capsulotomy. I think we need to dial down the interventions instead of climbing all up the way up the ladder. So comparing methods of treating capsular contracture, you can see capsulectomy and ADM on the left, open capsulotomy on the right. Almost all the advantages are in open capsulotomy. So let's talk a little bit about cost. Dr. Hidalgo was mentioning that it takes up to 5.5 hours to do this procedure. The costs can equate to buying a small car. So I just looked up how much is a small car. $26,000, but I have a hunch at Weill Cornell University, you're just getting started at $26,000. Whereas a capsulotomy, if you're a patient of mine and I've done your breast augmentation, I charge you for the operating room and the anesthesia. It's cheap, it takes 20 to 30 minutes. Patients can be back to work in a few days. So here's an example of this patient. This is just a linear open capsulotomy. Could hardly be easier. Often I put the same implant in, but often there's a reason to replace it. So it's an overlooked but effective treatment. 22.7% recurrence rates. They're easily treated, not to be dreaded. Very little recovery time, very little expense, no insurance billing, no pathology. So I've been in practice 35 years now. I have yet to do a third open capsulotomy on the same patient. So I'm not getting an endless cycle of capsular contraction, capsulotomy. If I did have to do a third treatment, no big deal. Remember, we're not traumatizing the breast. This was very scary for me to see people actually recommending ADM in primary breast augmentation. And why why are the contraction rates lower using ADM? Well, first of all, there's some flaws in this recent analysis. The authors did not recognize the significant selection bias and chronology bias among these papers that undermine these conclusions. But often, this treatment recommendation is regarded as the kitchen sink. Nothing more can be done if capsular contracture recurs. Now, you've got to have a backup plan. You can't tell a patient, we're going to do this. If it doesn't work well, we did everything we could. That just doesn't cut it. Again, you look at the payments to the plastic surgeon authors, and it's important to realize that ADM actually contains donor DNA that's packed with nuclei. It's not acellular, it's not sterile. So in conclusion, mesh and ADM, they're unnecessary for cosmetic breast surgery. Be aware of COI, insist on standardized lateral matched images, and use mammoplasty, basically use the vertical mammoplasty. And use open capsulotomy alone for capsular contracture treatment, and rarely perform capsulectomies. Thank you.
It's open for discussion. Go ahead.
Thank you. I enjoyed the talk. So you're doing the open capsulotomy, but there's a 22% failure rate. What are you doing for those failures?
They come back and I do it again.
And then what's the failure rate?
13%.
So it goes from there to there. Would you think, I mean, some people can't afford ADM. If you had a failure, I also do the open capsulotomy in round 1. In round 2, I go to ADM.
Don't do that. Just do another open capsulotomy. Save your patient a lot of money.
It's those 13%, they're going to be pretty upset.
No, they're not. It's such an easy procedure. Even if they have, remember I told you, I have not had a patient come back for a third one. So it's that.
Think they went down the street?
They might have. They might have. That's a good point. But you know, that's true of any study.
True.
Yeah,
Yeah.
that's true of any study.
Thank you.
So that was an interesting talk, Dr. Swanson, as always. You mentioned a lot about not using ADM for capsular contracture, and obviously there's some disagreement about that. But what about things like recurrent malposition, bottoming out, other reasons that you may consider using a mesh or ADM, particularly like in a weight loss patient, for example?
So I do a fair bit of weight loss surgery. I've never found an occasion to use ADM. I just never use it. I make use of conventional treatments. As you know, I do vertical mammoplasties. I make use of the existing capsular material. I've not had to use a foreign material.
Dr. Santinelli?
Thank you very much, Eric, for your excellent presentation. One simple question. When you talk about capsulotomy, are you dealing with the textured capsule or with smooth capsule?
Well, most of these are my patients, and so they have smooth implants. So most of the time they're smooth, but some of those were textured, yes. And I just make a circumferential linear incision, 20 or 30 minutes, that's all it takes. Thank you.
Last question.
Well, it's actually just a comment. Thanks very much. I enjoyed it. Even away from cosmetics and where you think it would be less debatable about in the reconstruction, if you actually look at most international series that aren't high quality, single center, single surgeon series, where you're going to get good results because they're dedicated surgeons, the use of ADM in the series around the world from multi-center sites shows increased complications. And so I completely agree. I think ADM's been normalized as this product that you're almost abnormal if you don't use it. But actually, in the everyday surgeon working in multiple small centers, it increases complications, and that's what the evidence shows.
Thank you. Some people regard it as the standard of care at this point. Thank you for that comment.